When an infant is born at less than 37 weeks gestation, their respiratory control centers are developmentally incomplete. The central nervous system struggles to maintain a steady rhythm, resulting in pauses in breathing. This chart tracks the incidence rate of apnea of prematurity against gestational age and birth weight. As birth weight and gestational age drop, the frequency of apneic episodes rises sharply. For neonates born prior to 28 weeks, or weighing less than 1,000 grams, this developmental disorder is virtually universal. Nearly every infant in this demographic will experience episodes requiring clinical intervention. To clinically diagnose these events as apnea of prematurity, the episodes must be recurrent and meet strict physiological criteria. The primary diagnostic threshold is any pause in respiration lasting longer than 20 seconds. However, shorter pauses also qualify if they trigger specific systemic cascades. An episode lasting under 20 seconds is diagnosed as AOP if it is accompanied by cyanosis, a drop in oxygen saturation of 4% or more, or bradycardia. Apnea of prematurity is driven by two overlapping mechanisms: physiological immaturity of the central nervous system failing to trigger a breath, and physical airway obstruction. Managing this dual pathology requires a highly targeted, stepwise approach. Recurrent apneic episodes frequently emerge in the first 2 to 3 days after birth, but assuming these events are simply a developmental delay is clinically dangerous. Apnea of prematurity must be treated strictly as a diagnosis of exclusion. Providers must first systematically eliminate acute systemic threats that manifest with identical symptoms. This means ruling out hypoxemia, assessing for systemic infection or sepsis, and checking for anemia. The differential must also account for environmental and pharmacological variables. An unstable thermal environment, either hypothermia or hyperthermia, can trigger apneic events, as can the administration of opiates to the mother before birth or to the infant postnatally. Next, evaluate the infant and their clinical record for congenital upper airway anomalies, like choanal atresia. The physician must also rule out severe neurological trauma, like intracranial hemorrhage, active seizures, and any electrolyte or acid-base disturbances. Only after verifying the absence of these immediate, potentially fatal pathologies can the care team confirm an AOP diagnosis and safely initiate the specialized intervention algorithm. For confirmed AOP patients, management begins with mandatory mechanical positioning to optimize the vulnerable airway. The infant must be cared for in the prone position, with head elevated exactly 15 degrees. Because these episodes are unpredictable, continuous cardiorespiratory monitoring for respiration and heart rate is required. If apneic events present with desaturation, continuous pulse oximetry must also be active. This monitoring sets the baseline. When an alarm triggers, the clinician faces a decision point. If the infant exhibits cyanosis or severe pallor, the provider intervenes immediately. However, without these severe indicators, the protocol demands a measured delay. The provider must wait exactly 10 seconds. This window provides the infant's respiratory center a brief opportunity to re-engage and self-correct the pause in breathing without external interference. This strict observation period prevents the iatrogenic stress of overtreatment. But the moment those 10 seconds expire without a spontaneous breath, the care team must immediately advance to physical escalation. When an apnea fails to self-correct within that 10-second window, intervention proceeds through a rapid progressive sequence. Step 1 is tactile stimulation. The provider applies direct sensory input by tickling or flicking the soles of the infant's feet, or stroking their abdomen. If this initial stimulus fails to arouse the central respiratory reflex, the provider must immediately advance. Step 2 targets potential airway obstruction. The provider performs a brief suction of the oropharynx to clear any accumulated secretions. Crucially, clearing the airway must be immediately followed by a repeat of the tactile stimulation from Step 1. If the infant remains apneic despite a clear airway and repeated physical arousal, the obstruction is likely anatomical. Step 3 requires mechanically adjusting the infant's position. The provider slightly extends the neck, which mitigates residual physical obstruction in the upper airway. These first 3 interventions are executed in rapid succession. They maximize sensory arousal and clear anatomical roadblocks, giving the infant every opportunity to resume breathing before the clinical team initiates forced mechanical support. When physical positioning and tactile stimulation fail to trigger a breath, the protocol shifts from encouraging spontaneous respiration to actively delivering it. The next intervention is step 4, the immediate application of manual bag and mask ventilation. This stage introduces a critical clinical trap regarding oxygen concentration. Providers must not automatically default to 100% oxygen. Bag and mask ventilation must be administered using the exact oxygen percentage the infant was receiving prior to the apneic episode. Flooding a premature neonate with pure oxygen creates severe oxidative stress. In the rare event that manual positive pressure ventilation does not stabilize the infant, the cascade reaches its absolute final stage. Step 5 requires advanced respiratory support. The provider must advance to either intubation and mechanical ventilation or nasal non-invasive positive pressure ventilation. Progressing from a 10-second observation window to full mechanical intubation is a rigorously controlled process. It ensures the clinical team deploys the exact minimum physiological force required to restore respiration. Acute interventions resolve immediate apneas, but managing the underlying disorder requires a chronic strategy to suppress overall event frequency while the infant's neurology matures. The primary pharmacological standard of care is daily caffeine dosing, acting directly on the brainstem to stimulate respiratory drive. This administration continues until the infant reaches 33 weeks post-conceptual age, demonstrating a pattern of infrequent, spontaneously resolving events. Once the medication is discontinued, a mandatory safety protocol dictates that continuous apnea monitoring remain active for 1 full week to ensure respiratory stability. For refractory cases where infants continue to suffer frequent apneas requiring stimulation despite caffeine, pharmacological management is augmented with mechanical support. Providers implement either nasal CPAP, set between 4 and 6 centimeters of water pressure, or a high-flow nasal cannula running at 1 to 6 liters per minute. These positive pressures are adjusted empirically until the frequency of apneic events drops. Chronic management relies on this dual-pronged approach, stimulating the central respiratory drive chemically while holding the obstructive airway open mechanically. Ultimately, apnea of prematurity is a developmental disorder. By mapping the incidence curve back over our developmental timeline, a clear exit point emerges. Apneic events typically decrease over time, often resolving entirely by 34 to 36 weeks post-conceptual age. This resolution aligns directly with the successful neurodevelopmental maturation of the infant's respiratory control centers. Managing this condition requires clinical precision, meticulous exclusion of systemic mimics, disciplined escalation during acute alarms, and sustained pharmacological support act as a vital bridge, sustaining the neonate until their premature brainstem can independently maintain life.